Hi, everybody. So we're going to begin our discussion on drugs used for the musculoskeletal system. We're also tying in some of the concepts of medications that we use for infection here as well, because it's inflammation, which is the process we think of with things like muscle and bone injury, stuff like that, is very, very related to the processes related to infection. So, inflammation is non-specific. Any type of damage in the body, no matter what that damage is, inflammation occurs from it. On the other hand, infection is related to a specific disruption of the body due to a pathogen. As we talked about in a previous set of overview, infection is a rather complex process, and so is inflammation. But the idea with inflammation is it's all about tissue repair, and these things actually happen together. So if you have infection, you have inflammation, but you can have inflammation without infection. All right. Inflammation is both good and bad. If inflammation is appropriate for the damage, it's good, right? But we can have inflammation that's also very inappropriate. So, signs and symptoms. We got your cardinal signs: warmth, redness, swelling, pain, and loss of function. There's 3 general stages. Stage 1 is our vascular stage. This is where white blood cells like neutrophils and macrophage, they show up. We get increased extravasation, meaning the white blood cells are stimulated to leave the blood vessels, and they come into the tissue. That leads to the swelling, that leads to the redness, that leads to the warmth, right? Those cells come in, and they start their work on clearing up the damaged tissue. And that kind of leads us to stage 2. This is our exudate. This is the drainage of the tissue. Once this stage starts, that's basically when our redness, swelling, etc., is all at its greatest level. As that starts to decrease, the damaged cells, the white blood cells, they're leaving the area as they've done their job. Think about it as kind of like a construction site. If you've ever seen a very large building being built, they actually dig relatively far into the ground to set the foundation. So you've got all these pieces of construction equipment that come in, and then they leave, right? And then new stuff comes in, and that leads us to stage 3. This is where we start to get cells coming in that aren't white blood cells. They're no longer cleaning up. They're building. So we get things like fibroblasts. We get cells related to creation of new blood vessels. We get, if it's a muscle injury, you start to see activation of satellite cells to help repair and donate cellular material to the other muscle myofibrils, right? So in this case, if stage 3 goes on too long, that leads to the formation of a scar tissue, and scar tissue is basically fibrotic, non-functioning tissue. So this is a normal process. Inflammation is good as long as our body is responding appropriately, right? Again, that means that the amount of swelling, the duration that it goes on for, the amount of pain, loss of function, etc., is all appropriate, right? If somebody, you're playing basketball and you jam your finger, you're going to get some swelling of the joint that, goes quote unquote jammed, and you shouldn't expect too much loss of function. In fact, a lot of people, if they have a loss of function, it's just because it's painful, so you avoid moving it. Well, if suddenly your finger swells up and it's so swollen you can't move it, that might be a more inappropriate response, and it would be worth potentially seeking a higher level of care rather than just rest, right? On the other hand, if somebody breaks their leg and the body doesn't have an inflammatory response, you won't actually heal the fracture. And that can lead to complications like non-union of the injury. So, key thing to talk about here is something called arachidonic acid. Arachidonic acid helps stimulate the production of prostaglandins, which lead to the creation of COX enzymes. These are cyclooxygenase 1 and cyclooxygenase 2. There's theorized to be more than two of these COX enzymes, but that's not been officially differentiated yet. But the idea is, and this is a key thing to keep in mind, COX-1 and COX-2 are often affected by our anti-inflammatory drugs like NSAIDs. They have different functions, though. COX-1 can be kind of thought of as a good COX. It stimulates, specifically in the stomach, it stimulates the production of the lining of our stomach that actually prevents the stomach from being destroyed by its own acid production. This is why when you're taking things like ibuprofen at too high of a dose and for too long, you actually get breakdown of your stomach tissues, which leads to gastric ulcers. And we'll talk about that when we talk about the GI system. Again, tissue repair, if it lasts too long, too much scar tissue eventually forms, damages function. Function is realistically the most important thing to think about. Anti-inflammatory drugs and autoimmune immunosuppressants can be key here, especially if the person does have an autoimmune disease related to connective tissues like lupus, scleroderma, RA, etc. So, anti-inflammatory drugs. Briefly, 5 classes. Okay, so first one we're going to talk about corticosteroids. We talked about these already. They function similar to the natural hormone cortisol. They are immunosuppressant by way of inhibiting the bone marrow, and bone marrow is where a majority of our blood cells of all kinds are made. Corticosteroids can be given in the body in almost any way, and it's going to depend on what we're targeting, how we're targeting it, etc. A lot of the side effects of corticosteroids in the short term is going to be things like hypertension and acne. In the long term, we actually start to see adrenal gland suppression. We see profound immune reduction, which is why they do use it in autoimmune diseases, and a Cushingoid appearance. As you'll see here, Cushingoid appearance, you get weight gain, truncal obesity, the moon face, the quote-unquote buffalo hump. Females start to get the hirsutism, where they start to develop body hair and facial hair. So it's one of those things where females are also at a higher risk of osteoporosis as well. So are males, but in general, it can be a problem. NSAIDs. These are taken for pain and inflammation, right? These are things we can get over the counter for the most part. Now, there are drugs like meloxicam that are prescription strength, but there's our COX-1 and our COX-2. There are some that are selective. There are some that are not selective. Unfortunately, the ones you get over the counter tend to be non-selective, which is why they can cause the effects long-term related to the GI dysfunction, increased risks of bleeding, etc. The COX-1 drug, when you think of aspirin, specifically aspirin, everyone knows that it's recommended for individuals with cardiovascular risk factors to take a baby aspirin, your 81 milligram aspirin daily. And that is because they're utilizing the side effect that COX-1 inhibitors have on increasing bleeding risk. And in those patients, it's therapeutic because they're at an increased risk for clotting, right? So what can be thought of as an adverse event in one area can actually be a treatment effect in another, all right? So it's important, again, to balance these things out. In children, very important thing to consider. Aspirin is not suggested to be used because of a condition called Ray's syndrome or Reye's syndrome. Reye's syndrome is potentially fatal, and it's related to giving a child aspirin while they have a viral infection, and it basically causes a lot of stuff to happen, and it essentially leads to coma, or I would say the more positive side effects, if they don't die from the condition, would be severe developmental disorder. Pregnancy, it's generally suggested to avoid during the first 6 months. It's category C, meaning that there are some known risks, but there's realistically risks to almost every drug in pregnancy. There's also some mounting evidence available from the NIH out of England. They have a what's called essentially a correlation between the use of ibuprofen in early stages of pregnancy and autism. It's only a correlation, and it's a rather weak correlation, but it does exist. And we do know that autism is related to inflammatory regulation, though we've seen that with specifically, studies with pregnant women that develop the flu. They actually have a much higher risk for their children to be autistic. And we've confirmed that in animal models. Now, obviously, we're not going to intentionally give pregnant women the flu in order to determine if their children develop autism at a higher rate or not. That's not good science. It's not ethical, right? So a lot of these things are still likely only ever going to remain causations. And the relationship of that ibuprofen to the potential development of autism is not understood at all. And in fact, everything we know about inflammation would actually kind of tell us that it wouldn't be straightforward to research at all to begin with. Antihistamines. So antihistamines bind to H1 and H2 receptors. H1s are in the blood vessels, and H2 are in our stomach linings. Basically, histamine causes us to create more secretions. When you think of your seasonal allergies, you start to get a runny nose, right? You start to get mucus that comes up out of your lungs. That is why you take antihistamines such as diphenhydramine or Benadryl. That's why you also can use them to help prevent anaphylaxis, especially if a strong rescue drug is not available. Because of that, this may not be as effective for certain processes related to inflammation. But again, inflammation has a large variety of presentations. So your watery eyes, hives, runny nose, that's all inflammation, right? So we want to prevent that when it's inappropriate. Side effects, we've talked about this before. Sleepiness, tachycardia, urinary retention, blurred vision. Extremely rare, though. You can see seizures, increased intraocular pressure. So people that have glaucoma are typically thought of not to take antihistamines. People with prostate enlargement and urinary retention also typically, stay away from them unless there's no other choice. Leukotrienes. So these are commonly used in prevention of inflammation related to respiratory mucous membranes. We want to reduce secretions and open up narrowed airways. One of the most common conditions it's used for is asthma. One of the most popular forms of this drug is a drug called Xolutin or Zyflo. I think Zyflo is the brand name. There's also Singulair and Accolate. They block the leukotriene receptors on the cells, and we get a reduced anaphylactic allergic response. Now, ironically, this can cause an allergic reaction. Anything can cause an allergic reaction, though. The liver, important to follow up on this. The patient develops jaundice, tenderness in the right upper quadrant of the abdomen, nausea, extreme fatigue after using it, major problem, and you do need to do periodic liver function testing. Next, DMARDs. So we talked about DMARDs already. These We're going to look at specifically the types that will inhibit tumor necrosis factor, TNF. There's different types of TNF, but in general, TNF is a inflammatory mediator. Typically, tumor necrosis factor enhances inflammation when it's a problem, and you're taking a medication because you have a problem. You typically do want to avoid DMARDs in people that have heart failure. You also want to avoid it in individuals with depression, gastrointestinal diseases, etc. Next, pain. So another thing to talk about, pain. Pain is a experience, it's a perception, and it's a sensation all in one. Pain affects everything. It's a physiological, psychological. It's often thought of poorly. It typically is a poor indicator of identifying how well treatment is going. But if a patient has uncontrolled levels of pain, it's important to address them as an entire person. So some of the more common pain scales that we'll use, you have your number scale here, 0 to 10. 10 being, I need to call you an ambulance right now. 0 being no pain ever. We have the Wong-Baker Faces scale. This is typically used for children and adults that have severe developmental disability. We have the Flack pain scale. This is used in infants. You're checking face, leg, their overall activity, their crying, and consolability, and you're rating on a scale of 0, 1, or 2. Because, again, infants can only essentially move their face, move their legs, and cry, right? So you check those things, and you get an idea of if the infant is in pain or not. So acute pain. Think of acute pain as the warning response of the body saying, hey, there is damage somewhere here. This releases the nociceptor that is stimulated by this releases a substance called substance P. And ironically named, P does actually mean pain. Substance P for pain. This leads to the creation and release of other inflammatory mediators like bradykinins, prostaglandins, etc. So pain typically is transmitted through the body from your peripheral nervous system. So your nociceptor is triggered. The nociceptor discharges, stimulating your peripheral nerve. So in this case, you've hit your big toe with a hammer. The nociceptor in the tissues are now screaming at the nerve saying, hey, 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 there's damage here. And in this very specific case, you're going to have transmission along your superficial fibular nerve that transmits all the way up the leg, eventually to your sciatic nerve, up to your lumbosacral plexus, and then it's to your spinal cord. This whole way, once in the spinal cord, it's going to synapse in a part of the spinal cord called the substantia gelatinosa. And this is basically functionally where something called your spinothalamic tract begins. Spinothalamic tract is the primary way in which the body transmits signals related to pain and temperature. That tract will go up 2 extra levels in the spine, and then it crosses the body. So when you've hurt your right big toe, the left side of your brain, in the parietal region of the brain, is what's actually interpreting those signals. So one thing to think about with pain is the idea of a pain threshold. Every sensation can be painful. So think about pressure, for instance. If I just rest my own hand on my arm, that's not painful, right? But if I start to squeeze my same hand on my arm, if I squeeze enough, that causes pain. You're starting to deform tissue if you squeeze hard enough. That's the idea of a pain threshold. Again, temperature is another great example for that. Here in Buffalo, I can go outside and there's snow on the ground, and if I'm outside for, 20 seconds and it's the middle of January and it's 0 degrees Fahrenheit and I'm just running a trash bag to the trash can, I could do that, But if you take someone who lives in Florida, for instance, and you have them do the same thing, they're going to experience pain. They're not used to that level. And it's the same way with heat, right? I'm sure everyone has, been visiting a friend, go to use their shower, and kind of just naturally set the shower to the same, handle position that you would in your own home. And oh my gosh, it's burning you, right? Well, you've reduced it a little bit, and now it's no longer painful. You just feel warmth, right? So any sensation can become painful under the right situation. Pain tolerance, on the other hand, though, is more of a psychological phenomenon. It's our ability to behaviorally and emotionally regulate how we respond to pain. Different individuals have different pain tolerances, and pain tolerance also varies by the individual in the situation that they are in. When we talk about acute versus chronic pain, again, acute pain is that sudden onset, identifiable cause, it's limited. That's the key thing. Chronic pain, on the other hand, may or may not have identifiable causes, and it can be related to psychological responses as well as permanent nervous system alterations. You actually get changes in your central nervous system, specifically in your thalamus, and it leads to this spillover effect where excess signaling occurs, and it leads to stimulation of an area called your periaqueductal gray matter, and that causes some stuff with your sympathetic nervous system. It causes this entire nasty overall response. And you can also see things like increased dendritic cells in the brain. It's an incredibly fascinating idea. But chronic pain will actually sensitize the nervous system to pain signaling. So your pain threshold that we talked about earlier, it reduces. So people with chronic pain, you might look at them and say, oh, you barely hit your leg on the door, on the coffee table. You barely hit your leg. Why does that hurt so much? Well, their body is so used to constantly using those pain pathways, they become sensitized. Their threshold of activation is severely, severely reduced. It's easier to activate them. So, drug therapy for this can be rather complex, and it can be very frustrating for patients, especially when we talk about opiates in a little bit. The drugs can also be a crutch for certain people, and some of them also have addictive tendencies. So controlled substances. Controlled substances in general, this is controlled by the DEA. We have what's called schedules. There's 5 different schedules. Schedule 1 are your most likely to be abused, and Schedule 5s are your least potential for abuse and addiction. Your Schedule 1s are the type of drugs that are very much under a lock and key. Their numbers are counted very regularly. In fact, in hospitals, you'll often see Schedule 1 drugs that are on the floor being counted at least once a shift to ensure that they are not going missing, and that proper documentation of who's prescribed them, who they've been prescribed to, and when they were given is all very important. Opiates, which are narcotics. The idea here is we're actually changing the way the body senses and perceives pain. These are highly addictive. They are Schedule 2 drugs. It is also possible to overdose on them, especially with long-term use. You do build up tolerance to them. And that is because of the way they work. They bind opioid receptor sites in the brain. As those receptor sites are bound, the body kind of stops responding to those signals as strongly and as much. So then you need more of a drug to get the same effect as before. Okay. Now it's important to consider opioids don't actually prevent pain. They just change our perception of it, right? The pain's still there. Adverse effects, though, big thing to think about is our respiratory depression, addiction, dependence, and withdrawal. So non-opioid pain drugs, these are often thought of as analgesics. You might often see these used in combination with each other, especially the next two classes we're going to talk about. Acetaminophen is a pure analgesic. Given oral, typically oral tablets, but you might see it in liquids for kids. Very toxic when taken at high doses and with alcohol, and there is risk for permanent liver and kidney damage. Pediatric, very, very important to follow labels. Typically, a weight-based dosage is key there. This drug, if an overdose does occur, they administer the drug acetylcysteine, which is given intravenously to help prevent liver failure and improve clearance of the drug. NSAIDs, we've talked about NSAIDs already. These help with inflammation. There is actually a lot of literature that exists that tells us that, especially in musculoskeletal patients, a NSAID combined with acetaminophen is just as effective as opioids for musculoskeletal pain. Okay. You also see some issues with opioids not being highly effective for certain types of pain. Opioids won't be super effective for nerve-based pain, which is why you typically, if you have nerve pain, you're given things like GABA type drugs. And we're actually going to be moving on to things related to that in a moment. Because again, antidepressants. We've already talked about the effect that this has on the brain, right? The brain, if the brain starts getting overstimulated with pain, it starts to become sensitive to that. So again, this is why you'll often see things like gabapentin, pregabalin, which is and pregabalin, which is Lyrica. You might see your triptyline drugs like nortriptyline, amitriptyline. Those might get used as well. Paxil and sertraline, brand name is Zoloft, will also be used for that as well. The idea with these is you actually can help increase the natural level of opioids in the brain. And people with chronic pain, they can have a permanent disability of some form that can limit their daily life. So they might be developing depression, not even from the pain, but from the fact that their everyday life is impacted, right? So there's, again, the whole body approach to these things, taking each individual's context of their condition and working within it. Anticonvulsants. Again, gabapentin and Lyrica can be used here. Prevent the electrical transmission of the brain and go for there. The doses for pain control will be higher levels than what's used to control seizures. So this can produce a pretty significant CNS depression. Muscle relaxants. So many different drugs work as these. Carbamates and cyclobenzaprine are two of the most common types. The idea with these is that if you have damage to a muscle, the muscle can undergo a variety of different processes that can lead to it spasming. Well, guess what? If the muscle's damaged and it's spasming, you're going to get even more pain than just from the damage to the tissue. Because if you're trying to use damaged tissue, especially when the entire purpose of that tissue is to be under tension, it's like taking a frayed rope. Once a rope is frayed, it's eventually going to break, right? All right, so moving on. We're going to talk about drug therapy for infections. We can be affected by bacteria, viruses, fungi, protozoa, and various other types of microorganisms. Bacteria. So it's important to remember that we have both pathogenic and non-pathogenic bacteria in the body. Pathogenic bacteria cause disease. Non-pathogenic bacteria do not cause disease. They might even live on our skin, in our GI tract, etc., and do very important functions for us. And guess what? Sometimes there are strains that are pathogenic and non-pathogenic. For instance, one of the most common bacteria to cause infection in the human is Staphylococcus aureus. Staphylococcus aureus comes in many different strains. Staph aureus, very important bacteria for our mouth, for our skin. Yet, pathogenic forms of it can get into our lungs and cause bacterial pneumonia, right? So it is important to remember that there's a distinction with that. The problem with antibacterial therapies is that they typically are not very specific. You can have narrow spectrum treatments. Narrow spectrum treatments only affect certain types of bacteria, and that can be based on certain factors like proteins in the cell wall, the ribosomes, etc. Another concept to remember is the idea of bactericidal versus bacteriostatic. Some drugs are bacteriostatic, meaning they prevent the bacteria from replicating. That basically meaning the bacteria doesn't get killed by the drug, but it stops it from replicating, which allows our immune system to catch up and destroy it. Bactericidal, on the other hand, allows for direct killing of them. Okay. When we talk about narrow versus broad spectrum, really it's all about the bacteria that are susceptible to it. In some cases, narrow is going to be more appropriate, whereas in other cases, broad spectrum are going to be more appropriate, especially if you're dealing with your average, upper respiratory tract infection. They might just give you broad spectrum, something like your amoxicillin, call it a day. No point in culturing most of the time, especially when there can be a wide range of bacteria that can cause these infections. Again, our intended response here: destroy the infectious pathogen, whether that is directly or by helping our immune system do it itself. One of the side effects you often see, though, is things like fungal infections can get increased from antibacterial therapies, especially in our GI system, genitourinary system, and in the mouth. So you can see thrush, yeast infections, etc. increase. Diarrhea also increases too, because the GI microbiome, all of the bacteria that live in there, if you're having a normal, quote unquote, healthy defecation, it's actually about 1/3 bacteria. And those bacteria actually give it a lot of the proper density and shape, so to say. There's a whole study on, well, I should say lots of studies, but there's a whole area of how our bathroom health can actually be a relatively good window into some aspects of our general health. So it's something I always encourage people to talk to their doctors about, especially if there's sudden changes with anything in the bathroom. It's very important. You can also see very rare side effects where certain types of bacteria that are normally controlled become uncontrolled. Things like Clostridium difficile. Very, very, very dangerous. Typically seen in individuals who get antibiotic therapy in a hospital. And it's highly infectious too. But when you don't have your quote-unquote good microbiome there to keep these other things in check, certain more pathogenic bacteria can actually become uncontrolled and start to colonize the rest of the GI tract. Types of drugs, in general, 4 classes, and they all target different things. This is a quick overview that shows them here. But in general, you have your protein synthesis inhibitors. These target the ribosome, generally. The cell wall synthesis inhibitors, these target the cell wall, typically a protein called lipopolysaccharide, or LPS. You have inhibitors of DNA synthesis and function. These are your fluoroquinolones. We'll talk about those later. And then you have metabolism inhibitors. These basically inhibit the ability of the bacteria to perform certain metabolic activities. Specifically, thinking about things like mitochondrial function. You're targeting the ability to produce energy. No energy means no cellular functions, no division, etc. Cell wall synthesis inhibitors. These are one of the more common types that are used. These are our penicillin-derived things, or cephalosporins, and our carbapenems. Also, vancomycin, another very commonly used thing here. What this does, these are bactericidal, and they prevent the bacteria from forming a cell wall. So essentially, as the bacteria starts to get larger, it needs to make its cell wall get bigger. Well, if it can't make the cell wall, it eventually is still creating all of the intracellular organelles and intracellular fluid, etc. It gets so big, the cell wall can't hold it in anymore, can't maintain the pressure, and it lyses, meaning it splits open. These are typically very effective for bacteria that grow on our skin and in our mucous membranes. So this is, again, highly effective for things that we typically are most likely to be infected by. Things like your Staphylococcus aureus, your strep, and also your strep type bacteria. And again, relatively broad spectrum because of that. So you'll see those drugs used often, especially your penicillins. Protein synthesis inhibitors. These are your aminoglycosides, macrolides, and tetracyclines. These can be a little nastier in terms of side effects, but again, not that big of a deal. What these do is they target the ribosome. All they do is, just like their name says, they shut down protein synthesis. They work at different points, though, of the process, which means that certain classes of these protein synthesis inhibitors may be more or less effective for certain types of bacteria. Macrolides, if you're looking at the list of side effects here, macrolides are notorious for their GI side effects. Tetracyclines have a rather characteristic photosensitivity response, meaning people that are exposed to the sun while taking them develop a rash, and they get very, very serious sunburns with minimal sun exposure. Certain other ones like clindamycin, if it's given in a intramuscular injection, it can cause something called thrombophlebitis, which is basically an inflammation of the vein, which can be dangerous. There are lots of side effects to think about here. Macrolides have a ton of drug interactions, which is why you don't see them used that often. A lot of these, though, can help suppress your immune system as well and reduce liver function. So metabolism inhibitors. These are your sulfonamides and trimethoprim. These are primarily used for urinary tract infections, typically used in more anaerobic-based bacteria because of that. There's not a lot of oxygen, obviously, in the bladder and the urinary tract. So these drugs work a little bit better for those. Sulfonamides do carry the risk of increased kidney stones, renal liths. So that's another thing to consider. Sulfonamides also do tend to have a decent amount of medication interactions as well as photosensitivity. And interestingly enough, because of their mechanism, sulfonamides specifically can be useful for non-bacterial type infections. Next, fluoroquinolones. Fluoroquinolones are a DNA synthesis inhibitor. One of the specific ones, lomofloxacin, increases sensitivity so much that serious sunburns can happen in a matter of minutes in highly affected people. Another thing to watch out for this is that it has very, very severe potential for adverse side effects. It can cause heart arrhythmias, including something called a prolonged QT interval. When we talk about cardiovascular diseases later on, you'll see that on the EKG. But basically, the time from the Q point to the T point increases, and that can be incredibly dangerous if the patient has other dysrhythmias as well, or if they have hypokalemia, which is reduced potassium in the blood. Fluoroquinolones are also linked to connective tissue damage. People that take fluoroquinolones for at least 6 months after taking it are actually at risk for damage to tendons and ligaments. This is a rather lesser talked about side effect. You can also see people with fluoroquinolones being at higher risk in the term after taking the drug for things like vascular wall dissections, where the inner lining, the tunica intima of the blood vessel, actually separates off from the rest of it, and it essentially stops blood flow through the vessel. One other important thing to talk about is antibacterial drug resistance. These are your superbugs, quote unquote, things like MRSA, your methicillin-resistant Staphylococcus aureus. Streptococcus pneumoniae is also another more common one. And there's also a vancomycin-resistant enterococcus, or VRE. These bacteria, have come around from the overuse of antibacterial drugs over the years. They are linked to increased use of bacteria in livestock and things like that. So they're very dangerous because we're having to use drugs that have worse side effects and whatnot for them, and people tend to have to be admitted to the hospital because of that. Next, the virus. So this is our virus here. You can see that basically the virus has just a handful of components to it. Viruses are non-living, but they are made up of either DNA or RNA. They are going to basically break into the cell, typically with the use of something called a spike protein. That spike protein helps it bind to the cell, and then it breaks through the cell wall, breaks into the cell, and then it hijacks the cell. It's basically like invading a factory and then using the factory to make whatever it wants to make, which in this case is literally just different parts of the virus. The virus does nothing but attempt to invade cells in order to hijack the cell to make more of itself. Typically, antiviral therapy is viral static. It does not kill viruses. It only helps shut down their production and growth. The idea, though, is the earlier into the infection you can take it, the more likely it is going to be effective. So when you talk about something like Tamiflu, for instance, Tamiflu is highly effective if taken within the first 48 to 72 hours of a flu infection. Anytime after that, though, it's kind of useless. So, two very common antivirals, acyclovir and valacyclovir. So basically, you see VIR on the end of a drug, think antiviral, right? These guys are used in things related to your human herpes virus families, which includes all the stuff you see here, like Epstein-Barr virus, which is human herpes virus 9, cytomegalovirus, herpes simplex, types 1 and 2, your varicella zoster, which is your chickenpox vaccine, or not vaccine, your chickenpox virus, and your shingles virus. It's all the same thing. Side effects for this, very generic: headache, dizziness, nausea, vomiting. Just about every drug you'll ever see has those side effects, and that's, again, related to the way that drugs are researched and side effects are formulated. Adifovir and dipivoxil. These guys can cause issues with other drugs. and can be highly toxic to the liver and kidney. And individuals that take retroviral drugs typically will not take this one either. And we'll talk about retrovirals in a little bit. Amantadine and rimantadine, these guys are typically used for respiratory tissues. So you see them used in influenza A. Amantadine is contraindicated for people that have glaucoma and urinary retention as well. Ribavirin, this suppresses viral reproduction as it is essentially a counterfeit, quote unquote, counterfeit type base to suppress the virus's action on the cell. This is one that's normally saved for viral infections that aren't responding to something like a cyclovir. And you can kind of see why. It's a little bit more of a nastier drug, right? It's not going to be your more first-line drug. You do see it more likely to be used in people with chronic hepatitis C, as well as for children with respiratory syncytial virus infection, RSV. They'll use this with a combination of interferon, and interferon is another cell signaling substance. So again, what we're looking at here is something called neuraminidase inhibitor, neuraminidase, with these two drugs, zanamivir and oseltamivir. These guys basically exist to treat flu, specifically both influenza A and B. So just about the most common flu infections that we get in general of all kinds. Neuraminidase. So when you talk about the flu, you always see it classified specifically in influenza B. You hear like things like H1N1, right? The N in that stands for neuraminidase. Neuraminidase is one of the enzymes that the flu uses to get into the body. It actually helps break down the cell. The H stands for hemagglutinin, and hemagglutinin is responsible for doing just that. It's a glutenin, meaning it causes binding, and hema, blood, right? So in this case, it inhibits neuraminidase of essentially all types. So you inhibit that, it helps prevent it from getting into the cell. If it can't get into the cell, it cannot hijack the ribosomes and the mitochondria and all the other organelles, and it cannot make more copies of itself. Retrovirus. So when we talk about the retrovirus, we're talking of human immunodeficiency virus, HIV. Retroviruses are very special. They always use RNA, and they're highly effective at avoiding the immune system and highly effective at causing infection. Basically, if you have HIV, you're at risk of developing AIDS. Not everyone with HIV develops AIDS. AIDS is your acquired immune deficiency syndrome. AIDS is basically an HIV infection that has run rampant for long enough that you actually see destruction and basically lack of function in your T helper cells. T helper cells, you can kind of think about them as like air traffic control for your white blood cells, right? They help release signaling factors that attract other white blood cells and control the overall immune response, and are very, very important for essentially telling your cytotoxic or your killer T cells where to go and what to attack. People with this also end up with opportunistic infections. So you see stuff that doesn't normally pop up in other people. So this is the life cycle of HIV. It's broken down to 12 stages here, and there's different classes of retroviral drugs you see along the bottom. These drugs work at different points of the life cycle. So antiretroviral therapies, again, they don't kill the virus. No antivirals do of any kind. They're virostatic, and they're given in cocktails, meaning you get a combination of these drugs. One of the most commonly used forms is HAART, which is highly active antiretroviral therapy. It's 2 to 3 different retrovirals. Again, you affect more steps of the HIV virus life cycle, you are more likely to be successful in preventing active infection. Now, retrovirals can also become resistant to this, and it is essentially associated with not keeping up on your drug doses. It's important to monitor the overall person's health, their liver problem, glucose levels, etc. So you're checking for jaundice, skin rashes, etc. NRTIs. So these drugs are reverse transcriptase inhibitors. They basically shut down viral DNA synthesis. So what happens is retrovirals are RNA based. We already talked about that. Well, our body has to kind of make DNA, right? Well, if our body is using DNA to make proteins, how is the retrovirus going to make more RNA for itself? It uses something called reverse transcriptase. It's an enzyme that basically takes the DNA that our body will make and then convert that into the RNA that is then used for the viral reproduction. So in this case, the retrovirus brings its own reverse transcriptase with it, and we want to shut that down. In NRTIs, same idea. These, though, bind directly to the enzyme. So they stop us from being able to convert viral RNA to DNA, right? So it's the same general idea as the NRTIs, though. PIs, these are taken into the actual HIV-infected cell. These are protease inhibitors. So protease is an enzyme that is used to cleave large proteins apart, especially proteins that are freshly being made. What you see in this case with the protease inhibitors is the inability to actually activate the proteins. So you get this non-functional mass of protein that can't be cleaved into its active forms. This does increase function, like damage to the liver, increases your blood lipid levels, and it can be rather dangerous for people with conditions like heart blocks. Older adults, if they're taking protease inhibitors, there is a lot of drug interactions with this drug. So this person, specifically because older adults are more likely to take lipid-related medications and cardiovascular medications, important to consider that. Integrase inhibitors. So raltegravir is the standard for this drug. This one's only given for people that already have HIV and are already using HAART and have increased viral loads, right? So they basically have an active ongoing infection. So there's an enzyme called integrase. Integrase has a somewhat complex function, so we won't dive too much into it, but the idea is you're inhibiting that enzyme, and that enzyme plays a major role in helping cause replication of the viral RNA, because it helps stop the RNA from being essentially integrated into the nucleus of our own cell. Fusion inhibitors, these block the viral docking protein from fusing with the host cell. So again, this helps prevent the virus from ever entering the cell to begin with. Entry inhibitors, same thing here. But these are a little bit different because they block a specific receptor, the CCR5 receptor, on our CD4 positive T cells. That's basically just fancy talk for our T helper cells. You have CD4 positive and CD8 positive T cells. Sorry, CD4 is your helper T cells. CD8 is your cytotoxic T cells. This is, again, HIV targets those T helper, which are your CD4 T cells. CD4 is that it's one of those markers when we talk about self-antigen that we think about, right? So it's a classification of those. There are also drugs used for prophylaxis to help prevent sexual transmission. One of the most common is Truvada, and it's for HIV-1 negative patients to take if they have a partner that has HIV-1 positive. Again, these do not replace your traditional STD, STI based practices to prevent the spread of infection, and testing at a regular point is suggested. One final thing to talk about, a couple more final things to talk about. Tuberculosis. Tuberculosis, not very common in the developed world, but it's still a rather dangerous condition that can affect almost any part of the body. It is spread through aerosol droplets, and it's rather easy to diagnose as well. In fact, if you work in healthcare, you're going to be getting yearly tuberculosis screening done, whether that is through your standard Mantoux test, which is your PPT test. You know, they do the little bubble-looking injection under the skin, and they're looking for the body to have a immune response against that. So if it enlarges more than a certain amount, your body has had exposure to tuberculosis before, and then you have to have a chest x-ray follow-up. And chest x-ray is pretty much the way you would confirm in those people whether they have TB or not. TB can also go dormant into the body. You can end up with essentially a walled-off mass of tuberculosis in the lung. And at a later time, that walled-off mass can get broken open, and tuberculosis is now free again. So you can have a reactivation and secondary TB at a time. Anti-tubercular drugs, again, you are aiming for preventing the spread of the condition, and secondarily, realistically, trying to destroy the Mycobacterium tuberculosis infection. So a combination is typically used. You're going to see drugs like isoniazid to inhibit enzymes for the Mycobacterium metabolism. You use rifampin to prevent reproduction of the organism itself. So again, you're looking at two bacteriostatic type drugs. And then pyrazidamide reduces the pH of the intracellular fluid, which actually then leads to more enzyme dysfunction and is actually essentially bactericidal. Intended responses: reducing cough, reduce sputum production, reduce the risk of spread. If it's aerosol related, the person has TB and they're coughing, it is leaving the lungs. That's a problem. You also want to do regular sputum cultures to ensure that the culture eventually becomes negative. Adverse effects: these drugs are highly toxic to the liver, and they potentially interact with lots of other drugs. If a patient is drinking alcoholic beverages and using acetaminophen while taking these drugs, there is a high risk of going blind. Fungal infections. So fungi can be rather tricky to treat. We often treat fungi with antibacterial drugs because there is a little bit of overlap there, but genetically, fungi are so similar to us that it is almost impossible to specifically target them. So if we're talking about fungi on the surfaces of our body, like our skin, we can apply topical treatments to them, and those can be highly effective, right? But unlike us, fungi have a cell wall, which also makes it tough to target them. There are different types of drugs. So you have your topicals for superficials and your drugs for systemic or internal infections. Those are like your azoles or polyamines. Just like antibacterials can be bactericidal and bacteriostatic, these drugs can also be fungicidal or fungistatic. So antifungal drugs, the three classes you see on the screen here. There is a substance called ergosterol very similar to our cholesterol in their plasma cell membrane. We use these drugs to prevent them from making ergosterol. So their membrane is not healthy, and it ruptures, and it makes it easier for the fungus to essentially die itself, or our white blood cells to attack it. There are spindle fiber inhibitors also. Spindle fibers are part of the structure of funguses. So if you have, again, another structural deficit, it makes it easier to destroy. Intended response, very straightforward. A lot of times, though, side effects to this can be rather interesting and depends on the type of medication that you're using. So you can have changes in food taste, especially if you have something like a thrush infection in the mouth and you're using like a topical mouthwash or a cream or something for the tongue, something like that. You can get changes in the taste of your food. But again, lots of general stuff. Now, there are concerns for people that have liver damage, reduced kidney function. People can have sensitive skin and may not be able to use a topical, which can be rather unfortunate. And these can also increase your risk of infection because, again, they can have some effects on naturally occurring bacteria, which can be quote-unquote good bacteria. As we already talked about, if you damage your good bacteria, you can actually increase your risk of infection. So that is everything for our musculoskeletal integumentary type chapter, as well as infection control type stuff.